Good evening. Hope everyone experienced a wonderful holiday and a happy new year to everybody out there. Welcome back. This is my week 4 soap note for cardiovascular system. I had the opportunity to meet a patient who goes by JT. He's a 56-year-old black male. He reported to the office today with a chief complaint that he was having chest discomfort because he was hearing a heartbeat in his ears. JT, he's a 56-year-old black male. He presented with frequent chest discomfort and reports pulsatile tinnitus. He works as a construction worker. He's a contractor. His job is physically demanding. He reports 10 to 12-hour long work days, and he really hasn't seen a provider in over 20 years. His symptoms have been intermittent. They've been going on for several months. And at this point, it's been very noticeable over the last few weeks. So he's been having chest discomfort. He feels like it's a pressure sensation and occurring both at rest and with exertion. There's no radiation when it comes to the pressure in his chest. He denies syncope and he doesn't have no known cardiac history. He came into the clinic today because his mother insisted that he get himself checked out. He recently lost his father just this past December 2025 to a heart attack. And so he does report that he occasionally uses Tylenol and ibuprofen for minor aches, mainly lower back pain from work-related soreness. He denies any known allergies. He hasn't been vaccinated in the last 5 years, but does report that he's compliant with all adult vaccinations. He just doesn't prescribe to any flu vaccines, COVID vaccines, or any other vaccines in general in the last 5 years. Like I said, he does take over-the-counter Tylenol and ibuprofen from time to time. He doesn't have no known allergies. He is not being followed for any chronic disease management at this time. And when it comes to family history, as I said, his father is deceased. He passed away at age 75 from myocardial infarction. His mother, she's alive. She is 73 years old. She is overweight. She is a type 2 diabetic. She has some hypertension, and he did report that she has high cholesterol. He does have 2 sisters. One's 53 years old. The other is 50 years old, and he doesn't know of any medical concerns at this time. Regarding his social history, he is a contractor, as I said, by trade. He is divorced and never had any children. He is a non-smoker but does drink. He drinks on the weekends. Reports that he has 2 to 3 beers every Friday and Saturday. He denies illicit drug use at this time. On the review of symptoms, he reports frequent chest discomfort or pulsatile tinnitus. He denies any syncopes, no murmurs, no edema, respiratory system. He denies shortness of breath. He had no cough, no auditory wheezing. Neurologic, he reports the heartbeat in his ears. He denies dizziness, any focal weakness, and vision changes. When it comes to his endocrine metabolic, he does have some central obesity. He denies polyuria or polydipsia. Musculoskeletal, reports chronic aching low back pain related to his construction work. He denies fevers, chills, and he has no intentional weight loss. Vital signs were fairly regular, 98.4. His heart rate was 88 beats per minute. Respirations 18. His blood pressure was 155 over 92. And his O2 sats were 98% on room air. He's alert oriented times 4. He does have central obesity, and he was in no acute distress. Physical exam, he had a regular heart rate. S1, S2 were present. No murmurs, no gallops or rubs. His peripheral pulses at +2. Bilaterally, he had no edema. When it came to respiratory systems, his lungs was clear on auscultation. Bilaterally, no wheezing, no rales or rhonchi. He was alert and oriented times 4. His cranial nerves 2 to 12 were grossly intact. He had no focal deficits. No carotid bruits. Tympanic membranes were intact. Like I said, abdomen, he did have central obesity. It was soft, non-tender, bowel sounds present, times 4 quadrants. And he has no abnormal bowel movements. Musculoskeletal, he had full range of motion. He did have some mild low back pain upon the physical assessment. For the differential diagnosis, the primary diagnosis is essential primary hypertension. The second would be atherosclerotic heart disease of native coronary artery with other forms of angina pectoris. And the third would be palpitations. We don't know at this time if it's vascular or hypertensive etiology. The working diagnosis would be essential hypertension. And so today, since he came into the urgent care, we were able to get him a 12-lead EKG that was normal. So then we sent him right away to the labs, and he did a CBC, CMP, lipid panel, HbA1c, and a TSH. We also ordered a urine microalbumin, and we discussed potentially the next steps of having a cardiac stress test or an electrocardiogram if possible. We did start him today on amlodipine 5 milligrams daily and chlorthalidone 12.5 milligrams daily. We did also start him on a statin 20 milligrams PO nightly. We are going to wait for the labs and we want to see that to make adjustments. But because of his symptoms and his presentation, we felt best to start these medications now. In addition to that, we did describe nitroglycerin 0.4 milligrams, sublingual PRN for chest pain. And then we discontinued, tell him not to use any NSAIDs at this time. He was educated on hypertension, heart disease risk due to his familial history. Gave him education on DASH diet, weight loss strategies, limiting his sodium, as well as starting to exercise routinely. I educated him on limiting his alcohol consumption and gave him signs and symptoms of when to report to the emergency department for chest pain, shortness of breath, neurological changes, and when to call 911. We will be seeing him in 1 week for a blood check and to review the labs, and then to further discuss treatment plan regarding the stress test or the echocardiogram. It was a great visit, and I hope that he's all right, and I look forward to seeing him next week. Please add whatever your recommendations are. Have a great day.